And a good evening and welcome in to the latest in the series of MedStar Health's live forum events. I'm your host, Jamie Costello from WMAR-2 News. Thank you so much for joining us. This is the best visit to the hospital you will ever have. We have an ensemble here tonight, 8 doctors in one room to answer all of your questions here tonight for the next hour. And why are we here? Because 1 in 3 women will develop a cancer in their lifetime. That's why we're here tonight. So we're going to be talking about survival. We're going to be talking about empowerment in fighting women's cancers. So over the next 60 minutes, you'll have access to the greatest number of experts we have ever brought under one roof into your home tonight on your devices. And it's happening live as we happen right now. We're going to bring in MedStar Health, the Bel Air medical campus, beautiful here. So call everybody you know, get in the conversation by posting your comments and questions to the MedStar Health Facebook or YouTube page, and we'll get the answers in real time. How about that? And don't forget to share the live stream. Go to your page and so that your friends can reach out and watch this too, because it's very, very important. Let's start right now. Dr. Mahsa is the doctor here. She's the medical director of MedStar Health's Community Oncology. You know, I was reading here, Harford County is not, we go from Allegheny to Wycomico. Harford County is 9th as far as leading in cancers. Why is that?
So cancer is common everywhere, but we are trying to provide the best care in the same community to patients who require cancer care. In Harford County, we have MedStar Health at Bel Air campus, which is associated with MedStar Georgetown Cancer Institute. And we have a dedicated cancer center, infusion center, genetic counseling, breast center, radiation oncology, navigation, all the kinds of services that a cancer patient needs. Our cancer center across the board in MedStar Health are accredited by Commission on Cancer, by American College of Surgeons. And the MedStar Health in Baltimore Cancer Network has received full accreditation with commendation for many years. Our breast program also has accreditation by National Accreditation Program for Breast Centers. These accreditation bodies, they have very stringent and high standards to give this accreditation to cancer centers. We have been maintaining our accreditation for many years, which speaks to our commitment to excellence and high quality. So our physicians here at MedStar Health at Bel Air, they provide cancer care and they discuss their patients in weekly tumor boards. They present their cases, they review the images, they review the pathology, they talk with each other to come up with the best possible cutting-edge treatment for their patients. So that way, everybody in this community can receive the best kind of care. We also have 2 other centers in Baltimore, MedStar Franklin Square Cancer Center and MedStar Good Samaritan Hospital. They both have cancer centers, and we provide second opinion appointments within 48 hours for any patient who is seeking a second opinion, which is much shorter than many other centers.
All right, Dr. Mohebtash, tell me, it feels like every week we get a call, we get a text that someone in our family, a friend, has cancer. Is it because we're getting older, or is it because we're detecting it more, And that's why we're here tonight. That's why you're the medical director. But it is a scary time for any cancer.
Yes. I think we can still do better.
Okay.
We can strive for improvement. But the key to that goal is early detection and prevention.
Yes.
That's why we are here to that. If you look at this lavender light, which is, in this setting, that symbolizes 100 different types of cancer. And it's important for us to emphasize on awareness and education about early signs of cancer. But unfortunately, many cancers, they present at very late stage and do not present with symptoms. That's why screening is so important. Fortunately, we have a screening for many common kinds of cancer, like breast cancer, colorectal cancer, prostate, cervical, and lung cancer. So I think we can do much better if we adhere to guidelines for early detection.
We're going to do much better. Thank you, Doctor,
Sure.
very much for joining us here tonight, the medical director right here in beautiful Bel Air. All right, let's meet the lineup that we have here. All 8 doctors who are out here tonight. Let's meet them right now. Shweta Kurian is the director of Breast Medical Oncology and the High-Risk Breast Cancer Program If there's any one cancer that has moved mountains in raising awareness, it is breast cancer the most. And of course, October is Breast Cancer Awareness Month. Thank you, doctor, for joining us. Breast surgeon, Dr. Atsuko Okabe is here, and she's going to help us navigate the options when surgery is part of the breast cancer treatment plan. Thank you, doctor. Gastroenterologist, Dr. Dana Sloan is here. She's going to walk us right through the all-important screening for colorectal cancer. Not bad for a TERP. Way to go. A UM grad. Way to go. I love it. And we can't talk about women's cancers without a gynecological oncologist. And Dr. Mahdavi is right here on the end. Thank you, doctor, for joining us here tonight. What's the leading cause of cancer death in women 25 to 30? Surgical oncologist Dr. Ed McCarron is here. You don't have to stand up. Thank you very much. Dr. Ed is here. He's going to tell us what is going on with the treatment of melanoma that's coming up. Emily Kuchinsky. Emily should have her own show. I love this. It is certified genetic counselor. She's going to help us understand which cancers are hereditary. So stay with us to find out what you need to know if you have family history of cancer. Radiation oncologist Dr. Katherine Chen. Wait until you see the technology she's here to talk about. Fascinating about using radiation therapy. Safer and more accurate than even for killing all the cancer cells. Lung cancer is on the rise among younger women. We're going to find out what the experts say about that and learn more about new approaches in the treatment to find cancer from Dr. Duane Monteith, Regional Chief of Thoracic Surgery here at the Angelo Center for Lung Diseases. Thank you all, experts here tonight. Now, you know our experts. Let us know your questions. You can post them in the comment section right there on Facebook or YouTube, and we'll answer it right here live. All right, this year, according to the American Cancer Society, 1 in every 8 women will be diagnosed with breast cancer at some point in their life. It's the most common type, according to the American Cancer Society. And even with all the pink campaigns, it is still claiming 43,000 lives a year. So what are some of the symptoms that women should be aware of? Dr. Kurian, lead us off.
So, you know, as you said, 1 in 8 women will be diagnosed with breast cancer over their lifetime. So the common symptoms that you see for breast cancer, they could present with a mass. They could, when you palpate the breast or you feel your breast, you could feel a lump in the breast or in the armpit. You could have a discharge from the breast, which could be a bloody discharge, any color discharge other than a discharge which is milk colored. There could be change in the skin texture, where there could be thickening of the skin, tethering of the skin, dimpling of the skin, or similar things with the nipple that you see. Any changes like scaling of the skin can also be seen. So, and a combination or many of these symptoms together can denote that you may have breast cancer. Pain is also one of the symptoms, though not a very common symptom of breast cancer.
Now, not all screenings can detect, but the mammogram, how old should we be to get in and get a mammogram? How often? And what about the 3D imagery now?
So, yes, mammogram is the screening test that we recommend for diagnosing breast cancer. So if you look at the guidelines currently, we recommend women 40 years of age or older should get a mammogram once a year. And if you have a family member who has been diagnosed with breast cancer at a particular age, you should start getting your imaging or screenings done 10 years before the youngest member of the family who has been diagnosed with breast cancer. Generally, mammograms are done once a year, as I said, and let's say you are 80 years old but very functional, and we expect that you will do well for the next 10, 15 years of your life. You should still continue to get mammograms to help detect breast cancers earlier.
Can you bookend them for me? The youngest you've seen and the oldest you've seen.
The youngest I've seen is 21-year-old, and the oldest I've seen is 100-year-old.
Get out.
Yes.
100-year-old.
Yes.
Wow, that is unbelievable. And again, they had the pain and they went, I mean,
so different symptoms. Different symptoms, yes. I think the older patients generally may come with mass or a lump or may not have anything, and generally imaging is the one that diagnoses. Younger patients sometimes could have more aggressive disease and may actually come in with symptoms because you're not expecting to have a cancer at age 20. So you're not someone who's going from imaging or really looking out for it. So sometimes, correct.
All right, here, listen, we have a question come in early on our Facebook from Julie in Essex, who asked if breast cancer can be prevented And we went right to the source, Dr. Daria, for the answer. Listen.
There's not really a way that women can prevent breast cancer, but rather I recommend risk stratification or risk assessment, and then based on a woman's individual risk, we can modify different factors to try to reduce the risk of developing breast cancer. Risk stratification or risk assessment involves assessing a person's family history, their reproductive history, and a number of other factors that play into things that could increase somebody's risk of breast cancer. And then we determine a patient's lifetime risk of breast cancer to see if they qualify for enhanced screening, for instance. And then there's a number of things we can do to counsel patients on risk reduction.
Thank you so much. How about that? No waiting. You get right in on Facebook and all YouTube. Just send us your questions right now. How do you get this? A great response. Let me go back to Dr. Kurian. How do you identify high-risk patients? How do you identify them?
So basically, it all depends on your history, your personal history, your family history. So if you are someone who has had a history of breast cancer in the past or have a history of ovarian cancer, fallopian tube cancer, peritoneal cancer, or the same history in your family, you're someone who has a higher density. It also takes into consideration when you had your first child, how old were you when you had your periods, how many children did you have, did you breastfeed, or if you had a biopsy in the past that showed a high-risk lesion, all these identifies if you are a high risk. If you come from a certain specific ethnicity, like if you're Ashkenazi Jew ancestry, they are more likely to develop breast cancer. Or if you already have an identified genetic mutation that predisposes you to develop breast cancer, like a BRCA mutation. So there are multiple mutations that do that, but if you identify through your history or your family history, if you have other family members who have had breast cancer or other cancers, as I described earlier, you could be higher risk for developing breast cancer. And once you know your history and your family history, along with all this, there are different algorithms, there are predictive tools that are available. You can actually plug in these numbers and come up with a score that determines whether you're average risk, moderate risk, or high risk for developing breast cancer over your lifetime. And then we can decide what we can do to help decrease that risk for you.
All right. I think we have a question for you, doctor. Here you go. If I am stage 1 and grade 3 invasive IDC, will I need chemo?
So the question is, yes, if you have a grade 3 but stage 1 invasive ductal cancer, will I need chemotherapy? And that depends on a few factors. It depends on whether you have a hormone receptor positive breast cancer, whether you are triple negative, whether you have HER2, and depending on these factors, you may or may not need chemo. So it is specific, or you choose based on specific factors. Just because you have breast cancer of a certain stage and a type doesn't always mean you will need chemo or you will not need chemo.
All right, let's go to Emily. We can't run away from our genes, can we? We can't run away from who built us. And you are incredible what you do with genetic counseling here. Can you explain the importance of coming to see you if we think it's running in the family?
Yeah, definitely. Good question. Thank you. So genetic testing is important because you may already know you're a little bit higher risk, right? As Dr. Kurian and Dr. Abagasimi talked about, you may be stratified as higher risk. Maybe your mom has breast cancer. You have some other risk factors. But if that family history is due to a genetic mutation, your risk for breast cancer and possibly other cancers is now much, much higher. You may have started at 2 to 3-fold increased risk, and now having that genetic mutation, having that change in your DNA, elevates your risk 4 or 5 times higher. So it may introduce options that have previously not been offered to you, like preventative mastectomy or removal of the breasts, if your risk level is elevated that high. And then also, genetic testing has the ability to uncover that you're at higher risk for cancers that aren't even on your radar, or they're not even in your family history, because often these genetic mutations increase risk for multiple types of cancer. So the BRCA mutation is the most common cause of inherited breast cancer, but it's also the most common cause of inherited ovarian cancer. So it's important to realize that if you have a genetic mutation, we're probably going to be on the lookout for multiple types of cancer, but we can certainly develop that personalized, medical management plan based on your genetic results.
Cancer is in every family that I know. I mean, it's the aunt, the uncle, the grandma, it goes all the way down the family tree. Does that mean that I'm going to get it?
Yeah, so most cancer is actually not inherited. We think probably about 90% is not inherited, so about 10% is. And what we look for in the family that tips us off that maybe we are dealing with an inherited cancer family is kind of the biggest red flag I look for is early age of cancer onset, because a lot of cancer is brought on by aging. So when we see cancer around 50 or below, it really sends up some red flags that this may be genetic. Seeing cancer in multiple generations, the same cancers.
Let me ask you, how deep do you go in the family? How deep do you go?
We typically go, first degree, so siblings, parents, children, and then second degree aunts, uncles, cousins, and then even third degree grandparents. But if you know your family history, I'll take it. So I'll go as deep as, someone knows. The more information that you can give during your risk assessment and genetic counseling appointment, the better information we can give back to you. Because sometimes what we'll see, if a mutation is coming down from the father's side and maybe he didn't have any sisters, is we won't see any cancer, but we dig back to the great aunts and other female relatives, and then we see that there's a lot of breast and ovarian cancer, and that family actually does have a mutation, but we just didn't see it in the closer relatives because they were all males. So yeah, we definitely dig as deep as we can.
All right, Dr. Okabe, I'm sitting on the edge of the bed. My wife's there. All of a sudden, she finds out she's got breast cancer. Is surgery tomorrow?
Usually not. So there is a step-by-step process that we will go through. And sometimes we might do additional imaging, which might be breast MRI, to try to figure out.
But there are a lot of options, right?
There are a lot of options. And so we investigate what kind of breast cancer, and we look at what Dr. Kurian already mentioned a little bit. We call them the tumor markers. So is it the kind of cancer that responds to female hormones? That's usually a less aggressive type of breast cancer, so probably more likely to go directly to surgery. On the other hand, if it's what we call HER2 positive, a special protein on the surface of the cancer cell, very likely chemotherapy is going to be first, or triple negative, you may do medical treatment first and then go to surgery. So there's a lot of things to kind of decipher before we jump in and say, okay, surgery's right now.
How far down the road? How far from the diagnosis to you're on a table?
It can be as soon as a week or two if there are no additional workup, and we're pretty sure that, well, not pretty sure, we know that surgery is the best first step. Other times it might be 3 to 4 weeks, but breast cancer is not something that grows so rapidly, so that's an important thing for women to know. We don't have to go rushing you into surgery right away. We want to find out exactly what kind of breast cancer you have and individualize your plan based on all the best guidelines that we know.
But the best plan is we're seeing survivors.
Yes.
Survivors are walking around.
Yes.
And that's where you want to get to the finish line.
Yep, and I think every time I've checked the American Cancer Society site, we have more and more breast cancer survivors in this country. Correct.
And we talked about all the surgical options and the reconstruction. So that brings us right now to Dr. Mahdavi. Is uterine cancer the same as endometrial cancer? Is it the same?
Endometrial cancer is one type of uterine cancer. The uterus has two components. One is the glandular component that covers the cavity of the uterus, and the second component is the muscular component of the uterus. Endometrial cancer originates from the glandular component of the uterus. It's probably the most common type of uterine cancer. 95% of uterine cancers are endometrial cancers. Less than 5% of uterine cancers originate from the muscle component of the uterus and are called sarcoma. Sarcomas are, generally speaking, aggressive cancers, and even in early stages can spread to other organs.
Now, uterine cancer is more frequently diagnosed, and And according to recent data, of course, but ovarian cancer is ranked the 5th most frequent cause of death in women. And the incidence of these cancers are on the rise. What do women need to know about this?
So endometrial cancer is not only the most common gynecologic cancer, the incidence or the occurrence of endometrial cancer in the United States is increasing, is on the rise. And mortality or death from endometrial cancer is also on the rise. This is despite the efforts and the research that we have done to find novel treatments for endometrial cancer. So there are lots of work to be done to find the optimal treatment for endometrial cancer. As far as ovarian cancer, it's the second most common gynecologic cancer. Every year, close to 20,000 women are diagnosed with ovarian cancer. The major difference between endometrial cancer and ovarian cancer is that endometrial cancer is usually diagnosed in early stages. And in most cases...
How many? How many stages?
In most of endometrial cancers are diagnosed in stage 1, probably 70% of the endometrial cancers.
Yeah.
But and the reason is that in early stages of endometrial cancer, there are symptoms such as abnormal bleeding that that usually kind of make the woman present to the physician with the symptoms, and with the biopsy, the cancer is diagnosed. But ovarian cancer usually presents with very vague symptoms, such as dull, mild abdominal pain, some fullness, and in some cases, a feeling of fatigue and weakness, and when the symptoms, significant symptoms such as abdominal distension and nausea, vomiting present, usually it's in advanced stages. So ovarian cancer is usually diagnosed in stage 3 disease, which is a more advanced stage. And for this reason, the treatment of ovarian cancer is more challenging.
All right, we have a challenging question here from Sandra for you, doctor. How do you find a really good GYN oncologist that can do more than just laparoscopic or robotic surgeries? I require a complete open abdominal surgery, and finding a lot of GYN doctors don't have as much experience with this, much more in-depth, complex surgery, removing a large cyst.
That's a very good question. In some cases, we have to do open surgeries that require removal of the uterus, the tubes and ovaries, ovarian cysts, and removal of all visible cancer. In some cases, we need to remove a segment of the bowel, or even doing liver surgery and upper abdominal surgery to achieve the best outcome. So to find a good GYN oncologist, first, it requires adequate training. Most GYN oncologists in the United States have at least 3 years of fellowship training in addition to residency. And also experience matters, how many procedures they have done, and the outcome of the surgeries.
All right, doctor. Let me move on to Dr. Monteith right now. While breast cancer affects more women than any other cancer, we know that lung cancer has topped the list of deadliest cancers for decades here. And the American Cancer Society found that women between 35 and 54 are being diagnosed with lung cancer at an alarming rate. And that's much younger than expected for lung cancer. Doctor, you don't need to smoke to get lung cancer. Break that myth down for me.
Sure. So, according to the CDC, approximately 10 to 20% of people will get lung cancer and never smoked a day in their life. And so that is, really one of the big misconceptions of lung cancer, that is a smoker's disease. Other risks for lung cancer include exposure to radon, exposure to toxic materials like asbestos, and even things like diesel on the job. So, you know, definitely a big misconception about lung cancer.
All right, go up the steps, I'm out of breath. I'm coughing a lot. Does that mean I have lung cancer, or is that a sign?
If you were having those symptoms probably from smoking, there is a chance that you could have lung cancer.
What other signs?
Unfortunately, there are not many signs for lung cancer in the early stages, if any. And that's why lung cancer screening is very important, because the goal is to catch lung cancer in the earlier stages when it's more treatable. The later stages, some of the signs can include just feeling just generally tired or weak, loss of appetite, unexpected weight loss, a chronic cough, or coughing up blood sometimes. Those are going to be the more common signs.
It's often too late when I'm feeling that way and get in and something's not right, and then you spring lung cancer on me.
Absolutely.
So what do you suggest? Get in there, just get yearly checkups and make sure.
Yeah, so that really, again, emphasizes the importance of lung cancer screening. So lung cancer screening is done through a test called a low-dose CT or CAT scan. It's a quick 5-minute non-invasive test that has been very effective in terms of diagnosing people with lung nodules, which are generally the precursors to lung cancer. The overall effectiveness has been proven, time and again. Unfortunately, less than 6% of people that are eligible for lung cancer screening end up getting screened, versus over 70% of people eligible for mammograms getting it. Who's eligible? It's going to be anyone ages 50 to 80, and they've had to have smoked at least 20 pack years. So the way we calculate pack years is if you smoked a pack of cigarettes every day for 20 years, that's 20 pack years. Or if you smoked 2 packs a day for 10 years, that's 20 years. And then you have to be a current smoker or smoked within the past 15 years.
When you tell someone they have lung cancer, are they shocked, surprised, or they knew it deep down?
A lot of people kind of knew it deep down.
No kidding.
Because generally it is going to be, again, the smokers. And a lot of people, associate smoking, with lung cancer. Unfortunately, smoking can put you at higher risk of any of the cancers. And also the biggest killer other than cancer, which is heart disease. So, yeah, so it's unfortunately, some people are shocked, but I think the majority, kind of sensed something was going on.
Can you explain what is it, bronchoscopy again?
Yes. So,
can you explain it again?
Yeah. So in terms of actually diagnosing lung cancer, you have to get a biopsy. And the cutting-edge way of doing that is a procedure called robotic bronchoscopy. A bronchoscopy is pretty much it's like a colonoscopy for your lungs. It's a narrow tube about the size of a straw that has a camera on the end. And we go down the airways, and the robotic part is actually the pretty cool part about it. The system generates a 3D map of the entire lung. And just like GPS for a car, the system kind of guides you to where the lung nodule is, and you can get biopsies that way. So that's the latest advancement in lung cancer biopsies.
How long does it take?
The procedure can take about a half an hour to an hour. It's a same-day procedure. You're in and out, just like a colonoscopy.
Okay, doctor, thank you so much. All right, Dr. McCarron, you see this right here?
I sure do.
This here, this here, 3 on my back, 2
I'm
on
looking at them all. I'm looking at them.
Oh my goodness, skin cancer. Man, what the heck did we do in Ocean City on
That's
54th
right.
Street at the Bay? Unbelievable. We're out there, and is it because we're more aware of it now than we were before, or is it just catching up to us? All the sunning that we did, and now it's all coming back.
I think a lot of it is coming back to us now, a lot of those bad habits that we had back in the day. I think a lot of the public service announcements, getting the word out to avoid excessive sun exposure is going to make a change and going to improve things.
And it is the most rapidly formed cancer now that we know of, the skin cancer, right?
Absolutely. Skin cancers are the most commonly diagnosed cancers. I think we've all had a friend that has been diagnosed with a basal cell carcinoma or a squamous cell carcinoma, but as you know, those are the nuisance cancers. Those are the ones that can be cut out. They do require treatment. You do have to see a doctor. But of course, the one we're worried about is melanoma. And the reason why we worry about melanoma is because that's the cancer that can spread to other places.
Well, Jimmy Buffett.
Right.
I mean, who would have thought that Jimmy Buffett was going to die of melanoma?
Right, right. And you know, the thing with the melanoma is we always want to make people aware that if you have a mole that's changing in color or changing in size, definitely get a biopsy done. They're going to run some slides that go through asymmetry. So this first one here is asymmetry. So if we cut that in half and folded it over on each other, they would not be equal. The next one is, if you page forward one, will be the irregular border. That's the irregular border. And then if we go to the next one, we get the changes in the colors. So there's a lot of variation there, right? You have the black, the brown, the purple, the red. And then if we go to the next one, this one obviously would be bigger than a pencil eraser. So that's the ABCD. That's the D of the public service announcement. And then the last issue is an evolving mole. So we'll see a lighter one here. If we go to the next, then it gets very dark. So again, if you have any of these symptoms where things are changing on your body, you should definitely get checked out, because the earlier that you make the diagnosis, the treatments can be much easier.
Sometimes it looks like a scab and you pick, and all of a sudden the blood, and it just won't stop.
Right.
That's when you got to get in to see somebody.
Definitely, definitely.
Oh,
Yeah.
my goodness. All right, we have a question here. What is the difference between basal and squamous?
Oh, so those are the cells of origin of the skin cancer, and so the squamous cells are in the epidermis, they're like the most superficial cells. The basal cells kind of form the lower layer. So they all serve a different role. So the basal cells will divide and make the squamous cells eventually. So the squamous cells will slough. So basically, two different cells of origin for two skin cancers. And then in that epidermis, in that basal layer, is also the melanocytes that creates the pigment to your skin. Those are the melanocytes that make melanomas. And these are examples of patients of mine that I've treated in the office that obviously recognized they had a problem and came in for treatment.
How deep does it go into your skin? I mean, how?
I think that's the most important question, because the depth of invasion determines your risk. And many times the depth of invasion will determine the types of treatment that you require. So we want very superficial, very thin melanomas. And to be honest with you, my dermatology colleagues are doing a terrific job picking these things up. You know, what do they say, the ugly duckling? I mean, I'm always amazed at how the dermatologist can look at someone's back with like 25 moles and find it. Yeah. And they do it every time. I'm always amazed when I see the little biopsy site and I see the 20 other moles, and I'm like, why'd they pick that one, right? But they do a great job.
Have you everybody been in the dermatologist's office lately? The line is longer than a Chick-fil-A.
I have, and the lights are brighter there than here.
1,000 people. They're all, oh man. Let's go to Dr. Sloan. Thanks for waiting patiently, doctor. 1 in 25 are going to develop colorectal cancer. 1 in 25 women. And that's a late stage diagnosis before they even know it. Because the symptoms are easily dismissed. What are the symptoms, doctor, that we should be aware of?
So I think the first thing to realize is what we know is that colorectal cancer is the third most prevalent cancer in women, third most prevalent. It's important to understand that most patients who present with colorectal cancer actually don't have any symptoms, even at later stages. So we've heard it echoed amongst different doctors here, but the key is early detection and screening. That's really the fundamental premise of why we do intentional screening. We want to find these cancers at an earlier stage.
So you say colonoscopy from how old? I know that the men are, what, 50?
Right. Well, actually, it's lower. So the current U.S. guidelines for average risk individuals actually recommend starting screening at age 45.
45.
Right. For higher risk individuals, so those with a family history of colorectal cancer, those who have inflammatory bowel disease, those who've had abdominal pelvic radiation, women who've had prior radiation for GYN cancers, for example, may need to be screened much earlier. So the two most important things for women to remember is, number one, know your family history, talk to your family. Not everyone wants to talk about colon cancer and talk about colonoscopy, but talk to your family, and also talk to your provider. Understand, what's my risk and when should I start screening? How should I be screened?
Can you tell me about the test?
Yes.
And should everybody hold on to what?
It's no longer dinner time. We can talk about these things.
Here it comes.
So there are basically three main categories of screening. One is stool-based testing. The second is image-based testing, so like virtual colonoscopies, and the third is colonoscopy. So you might see some video here. I will say colonoscopy is what we offer at MedStar Franklin Square. Patients will come into our preoperative area, meet with their gastroenterologist, meet with the anesthesiologist. They'll have a family member sitting with them there. And we'll go over the procedure in detail. You get wheeled down our procedure space into the actual room. Once you come into the room, you'll be on a stretcher already. The anesthesiologist will be waiting for you in the room. You can see a lot of monitoring equipment here. Once you get into the room, the anesthesiologist is sitting kind of at your head. They have a lot, we're standing right there, a lot of monitors to monitor someone very, very closely. There's a lot of fearfulness around colonoscopy and being put to sleep, but really it's a very light sedation, enough to keep you comfortable and sleepy, and they watch you very carefully the entire procedure. Also in the room are going to be 2 nurses as well, along with a technician. So you're surrounded the entire time. You'll see me here holding a colonoscope. It's very skinny and flexible, has a little light at the tip of the scope. And while a person's on their side and asleep and resting comfortably, the camera will go inside and look throughout the whole colon. You'll see here the little ports here. We can pass thin catheters down the channel of the colonoscope. That will enable us to biopsy areas of concern, also remove polyps if we find them. 1 in 4 patients will have a polyp their very first colonoscopy, so we want to identify them and remove them. It takes about 20 minutes or so, 15, 20 minutes. The patients will then leave the room, go to the recovery area, drink some juice, and then go home.
The one complaint I have, doctor, is that why do you wake me up out of that great sleep?
Well, you'd like to eat at that point. At that point, it's time for lunch. You know, so,
what about the Yahoo and the Slurpee before we come in? Are we still drinking that?
So the preparation does involve a clear liquid diet, which is no fun, and also a laxative. But truthfully, we use a Miralax-based prep, which doesn't have any taste or texture. It's not fun to have to poop for a few hours, let's admit that, but it gets the job done and enables us to give you a higher quality exam.
Very good, doctor. Thank you very much. Man, I'll tell you, the youngest patient you've had to tell.
28.
28.
28. So this is actually a young woman who didn't know much about her family history, and I diagnosed her in February 2020, right before COVID hit, and so we were able to get her in quickly for her surgery. I think it's important to realize that even patients who need surgery for early stage colorectal cancer often don't end up needing an ostomy bag. There's, again, fearfulness around that. Okay. They don't need a permanent colostomy, and she did quite well.
I think we're getting another question up here. What's the advantage of a colonoscopy over other screenings?
Sure. So as I mentioned earlier, there are 3 main buckets of screening. Stool-based testing, like your FIT testing and your Cologuard, are non-invasive. There's no prep, there's no sedation. Image-based testing like virtual colonoscopy requires a preparation but no sedation. The disadvantage that those tests have as compared to colonoscopy is that if they're abnormal, you still will require then to have standard colonoscopy. So colonoscopy is for that reason considered to be historically the gold standard because it enables us to screen you and also remove polyps in one stage rather than having 2 separate testing done.
And again, just to emphasize again, chemo and radiation to treat this too.
Depends. So if an early stage colon cancer sometimes can actually be removed through colonoscopy. It's a technique called EMR, or endoscopic mucosal resection, where we can take it out at the time of colonoscopy. Patients with more advanced cancers, yes, they'll undergo surgery. If their cancer has spread beyond the colon, patients will be offered chemotherapy. Radiation is most appropriate for patients who have rectal cancer, so cancers forming lower in the colon. Those cancers are especially sensitive to radiation. They respond beautifully.
And doctor, here's a stupid question. The more polyps, the better the chance?
Not necessarily.
No kidding.
Not necessarily. There are certain hereditary polyposis syndromes, and those may increase a person's risk of colon cancer. But in general, again, 1 in 4 patients will have a precancerous polyp at the time of their index colonoscopy. And again, these are benign polyps. Okay. So we remove them, and we essentially, reduce the person's risk substantially of developing colorectal cancer.
Thanks for doing what you're doing, doctor. Oh, man. Let's go to Dr. Chen. Radiation. Fascinating. What a line. When do we get to that part in our cancer treatment? When do we start? The machines that we have today are just incredible. Tell us about that, doctor.
Yeah, I mean, not a lot of people know a lot about radiation. I think it's often can be scary. It's such a new thing for a patient, especially when they've just been diagnosed with a cancer. So, when I'm meeting a patient for the first time, we are spending a lot of time just talking about what radiation is, dispelling myths. So I'll give you the nutshell version of how it works. Basically, we are designing, we're delivering these high energy x-rays from outside the body into the area of the tumor, wherever we're worried cancer cells may be. Oftentimes we are doing this over the course of several weeks. That's something that sometimes surprises patients. But the reason we do that is actually for safety. You know, we're trying to be more gentle. We're giving a small dose each day so that over the course of weeks, the radiation is building up to a point where it can kill the cancer, but the body has a way to recover in between each of those days.
No kidding. Now, I've heard you're exhausted after radiation, but that's not, is that?
You can be tired. I would say that's one of the most common side effects of radiation. But otherwise, you know, the side effects that we deal with, they are just local to the area that we're treating. So sometimes patients ask us, you know, am I going to lose my hair from the radiation? Not unless we're shooting up here, and most of the time we're not.
Yeah, the thing that's fascinating is we look at the slides here and the pictures. A lot of people are intimidated. It's a machine.
Yeah.
And there's nobody around except the person's hitting the buttons, and then all of a sudden you're being zapped, and here we go. But it's a pinpoint thing, isn't it?
Radiation, modern radiation, it has come a long way, I'll tell you that. Our ability to shape the radiation dose where you want it to go, away from things that we're not trying to treat, has improved so much. We are treating day to day on a couple millimeters of accuracy, which is kind of amazing when you think about it. So overall, patients are getting less side effects. They are, you know, both during the treatment, also long after, and that's a good thing.
We have a question for Dr. Monteith here. This is from Sandy. If you have a positive CT scan, but a pulmonologist can't find anything, what do you do?
So my recommendation would be to go and see a lung specialist, such as a thoracic surgeon or a interventional pulmonologist, who, you know, we are equipped with tools to better find small lung cancers. And, you know, with early detection, we are finding smaller and smaller lung cancers nowadays. But, you know, there are a lot of new tests that can help, you know, find these smaller nodules, find these smaller cancers, and get them treated at the same time.
I know you face this question all the time. If you tell someone you have lung cancer, when is my treatment? How long is this going to take? What do you tell them?
Yes, so if it's in the early stages, you know, surgery is generally the gold standard treatment. If you're not strong enough for surgery, there are options that my colleague, like Dr. Chen, offers, which is called CyberKnife, which is just, you know, a targeted focus beam of radiation into the cancer itself. The timing for lung cancer surgery, it is a little bit longer than most because we do have to make sure that your heart and your lungs are strong enough to tolerate the surgery. Most people are, however, you know, in relation to other cancers, it's not as extensive a workup, but we do have to make sure that surgery is going to be the right thing, and you know, we can cure your cancer. We don't want you to have issues like a heart attack, you know, during surgery. So we're very cautious about making sure that you're strong enough for surgery.
Let me go, Dr. Chen. I skipped over the CyberKnife. Is this the greatest invention?
It is a really useful tool for what it does. So, like Dr. Monteith said, it delivers a very focused, very high dose, you know, radiation treatment. It's really good at treating small tumors, so early stage lung cancers, you know, even prostate cancer, which is not what we're talking about today, but you know, small spots of cancer in the brain. It really helps to spare radiation dose to a lot of normal tissue. So it's good at what it does, but oftentimes we are trying to treat a larger area. You know, we're trying to be more comprehensive. So it's not the best machine all around, but it is really useful when we can use it.
Here's a question for anybody who wants to answer. Who reads their body better, a man or a woman? Who can read their body better?
Women.
Women.
Yes.
I wasn't going to say that.
They know. They know. You're all been blushing. Yeah, we do. Here's a question from Nora. Hi, I'm a mom diagnosed with uterine cancer. When is screening for cancer appropriate? My children are in their 20s. Should I talk to my primary care or specialist? What tests do they need to take? Genetic counseling? Emily?
This is a very good question.
Okay, yeah.
Oh, I'm sorry.
Go ahead.
So, very good question. And about 5% of endometrial cancers, assuming that the uterine cancer is endometrial cancer, about 5% of endometrial cancers have genetic basis. In other words, it's caused by a genetic mutation that is passed from one generation to another. If you want to compare it with ovarian cancer, about 15 to 20% of ovarian cancers have genetic basis. So for endometrial cancer, and to answer this question, fortunately, we do special testing on all endometrial cancers. It's called mismatch repair gene mutation study. And that is basically a test that's done on the tumor, and it shows whether that tumor could be associated with genetic alterations or not. And that's standard for endometrial cancer as well as colon cancer. So in this particular case, I'm sure where she had her surgery done, they did a testing on her tumor. And if the initial testing is positive, then they do the blood test or the germline testing to determine whether that cancer is related to a genetic alteration or is a sporadic cancer. In this particular case, if the genetic test shows that she has a germline mutation, then her children should be tested. But if the initial test doesn't show that this cancer is related to what we call it the Lynch syndrome or hereditary cancer syndrome, then the children do not need to be tested.
And Emily, what do you think?
Yeah, I would just add, so yeah, Lynch syndrome is the most common cause of inherited uterine, but if that individual was diagnosed at 50 or below, and even if her tumor testing was normal, so not suggesting that it was Lynch syndrome, I would still recommend being referred to genetic counseling because there are other syndromes that can increase risk for uterine cancer and other cancers. So just to have that full risk assessment to make sure that that she's not at higher risk herself of getting other cancers, or if her children or other family members are at risk as well.
Okay, Nora, call in the morning. Call in the morning. All right, here's a YouTube question from Barry. Is it Barry? Any plans to do a colonoscopy in Bel Air tonight?
I'll be here until 8:30 there. But I'll say right now, MedStar Baltimore is offering colonoscopy at Franklin Square, my home center, also at Harbor and Lutherville, ASC. We are planning to expand to Bel Air. This is a gorgeous facility. So we are planning to expand here, but I don't have a timeline for that.
All right, Dr. Kurian, let's go back here. An oncologist. What is the difference between an oncologist and a medical oncologist?
So oncologist, if you talk, you could say you are a radiation oncologist, like Dr. Chen, surgical oncologist, like Dr. Okabe or Dr. McCarron, medical oncologist like me. So the difference is what kind of care we provide. A radiation oncologist treats cancer using radiation. Surgical oncologist basically does surgery on the cancers. And medical oncologist is the one that provides treatment beyond this in terms of chemotherapy, targeted therapy, immunotherapy, hormone therapy to treat your cancer. So,
and is Keytruda, is that a miracle drug?
So keeping away from the trade name, let's talk about immunotherapy, which is one. Keytruda is one of the immunotherapies. There are a lot of immunotherapy drugs available. Not a miracle drug, but certainly has changed the way a lot of cancers are being treated at this time. It is basically used for multiple types of cancers. There are probably only 2 or 3 different cancers where immunotherapy has not shown much response, prostate cancer being one, some of the brain cancers where we don't use, but otherwise, right now immunotherapy is being used for treating multiple cancers, breast cancer, lung cancer, it started with melanoma, and uterine cancer, and so it has basically helped us control a lot of different cancers. So it is not used alone in treatment for most cancers. You do combine it with other therapies. You do combine it with conventional chemotherapy or targeted therapy to get response. But I can tell you in terms of lung cancer, before the arrival of immunotherapy, patients who had advanced stage diseases, the outlook was not great. People lived many months, a year or so. But with the advent of immunotherapy, patients are living much longer even with stage 4 disease. So in some ways, yes, it's a miracle drug because we are seeing people survive even advanced stages of cancers with treatment with immunotherapy. It's a very unique concept the way it treats. Basically, it is harnessing the power of your own immune cells to treat your cancer. It is training your immune cells to identify cancer cells which kind of hide because they are very similar to your own cells. So it makes your immune cells smart enough to identify those cancer cells and kill them. So you don't see the side effects that you see with conventional chemotherapy, like losing your hair or blood counts dropping, but they still deliver a very effective treatment.
All right, let's get off script right now. I want to go to each and every one of you, and I want you to give people hope who are watching here. I want you to describe, not by name, but just by a success story, the greatest success that you've seen a patient come in. Let's start, Ed, we'll start with you. Give me the one story that keeps you going every day.
Oh gosh, I have a patient of mine that's been living and surviving with melanoma essentially my whole career. So I met her when I started over 20 years ago, and she'll have recurrences and then we'll treat them. And she may get another recurrence, and then we'll do it again. And again, immunotherapy has been a big part of her survival, and just an incredible determination over a 20-year period of survivals. And she's as pleasant as anyone could be. I mean, I think she's meant to be on this earth. So
there you go.
Yeah, what a wonderful story for her.
Right. Yeah. Emily, the one success, the patient that you have in your heart today.
Yeah, I think it's just a patient that just handled her results exceptionally well. She tested positive for a PALB2 mutation, which is similar to BRCA, and that increases risk for breast, ovarian, as well as pancreatic cancer. Her mom had actually had both breast and ovarian cancer, and that's where we first found that mutation in her mom, and so she had that 50% chance of having it herself. She got tested, and just handled it so well, decided to have her breasts removed and then eventually her ovaries removed, and has actually been so gracious to anytime, we need someone to do one of these events or for marketing, she's always willing to share her story. So it really just kind of echoing her words is like, knowledge is power. It can be hard to hear, and I see that at first with patients when they get that results that yes, it is hereditary in my family, but usually in the end they are glad to hear because it allows us to personalize their medical management and start screening earlier and more frequently and offering even preventative options. So yeah, she's definitely someone I keep close to my heart.
Dr. Chen, that one patient where you're told you're cured.
So hard to pick one.
That's good.
I've been seeing a lot of older women who have had these early stage lung cancers picked up on lung screening CTs, which is a really good thing. And there was one lady I saw recently, we treated her with a cyber knife a couple years back, and it's great. She didn't have to go to a surgery. She wasn't a candidate. We were able to do it non-invasively. Looks great. All the scans are clear. She comes in with her granddaughter. She's just living life.
Doctor?
So one was a 50-year-old lady, never smoker, that just happened to fall down her basement stairs one day. She went to the emergency room, got an X-ray of her chest. She did have a rib fracture. They did a CAT scan, and they found a lung nodule. We biopsied it. Turned out it was lung cancer. We were able to take it out, and she's doing well 3 years later, cancer-free. So falling down the stairs actually saved her life.
That's incredible. Gee, Doctor, how about it?
So I had a patient about 2 years ago, 70-year-old lady with endometrial cancer. She had surgery at a different hospital, and then she had recurrence of cancer. The recurrence was so bad that the cancer was all over the pelvis, and the cancer eroded through her abdomen and created a large wound that was all cancer. She received chemotherapy, which was not effective, and we tested her for the mismatch repair gene mutation, and she was actually mismatch repair deficient. So we treated her with immune therapy, same medication that you mentioned, Keytruda or pembrolizumab. Actually, she was ready to go to hospice, and the wound was so bad. And so within few cycles of immune therapy, the wound shrink quite significantly. And then I believe after the 5th cycle, the wound completely healed. And when we did the CT scan after 6 cycles of immune therapy, she had no disease. When I left that practice, she was free of disease. And this lady was ready to go on hospice.
Unbelievable. Doctor, top that.
I had a 46-year-old African-American woman, so it could have been my twin, came in several years ago for colonoscopy. And she was very scared of having a colonoscopy. She just didn't know enough about it. She was petrified. Came in, the nurse held her hand. We held her hand as she fell asleep, and did her colonoscopy. Most polyps are like the size of pencil eraser heads, very small. Hers was larger than a golf ball. So took it off and clipped it off, and the pathology came back as a villous adenoma, so an immediately precancerous polyp. I talked to her afterwards, and I said, if we had left this in for 5 more years, you probably would have had a colon cancer. So not only did she tell me how glad that she was that she came in, but she told her sister and her brother, got to go in and get screened, and they did. So, it's those stories that really keep me going.
Look at those lives you saved.
Absolutely.
Unbelievable.
Absolutely.
Doctor?
So I came to MedStar Franklin Square, I think about 2008, and shortly thereafter, a young woman in her 40s was diagnosed with breast cancer. We did the lumpectomy, the lesser surgery, and shortly thereafter was identified to have distant metastasis, which is, we call metastatic breast cancer. But it was only in one spot. So we call that oligometastasis, and it was to her scapula, her shoulder blade bone in the back. And she had CyberKnife, and she has done fantastic for years now. She does a great job promoting, breast cancer knowledge, breast cancer screening, just a very vivacious person, and she's done great.
That's great. All right, doctor, wrap it up.
So because I do breast cancer and there are a lot of patients who go through mammography, I have the advantage of seeing patients who come in with early detected breast cancers and being cured of their cancers and living very long. But I'll tell a story of this woman who came to me, and she was in her 70s, came in, was diagnosed with breast cancer with one area. We, as part of the imaging, because she had a triple negative breast cancer, we found that she had a spot close to her lung that was also a breast cancer. She was also diagnosed with a rectal cancer at the same time. All this was treated. Even though she had stage 4 disease, we treated her. She's disease-free now, almost 8 or 9 years out, with no evidence of her cancer at this time. So that's a very rare story. Not all stage 4s behave this way, but I have 1 or 2 patients who are like this, and that keeps me going to keep on trying for other patients if I see a disease like that.
Look at those 8 success stories and many, many more out there. Here's another question. We'll end it here with Erica. Is a clavicle nodule a sign of cancer?
So if you're talking about a lymph node around your clavicle, that's probably what I think what they're asking. It could be a sign of cancer. We don't know. That needs to be evaluated. You may have to have more imaging. That nodule may have to be biopsied to see what it is.
All right. Listen, hey, doctor, come on up. Come on up. The medical director, she's the boss. She's got to say it. All right, we're going to put this up here. Listen, if you are looking for cancer care near you, MedStar Health has experts here in Maryland, D.C. MedStar Health has the experts that you need to choose. Close to where you live, close to where you work. You can make an appointment at any of our locations by visiting medstarhealth.org, women's cancer. Well, keep the questions coming. They're going to stand by. They're going to work overtime tonight answering your questions and get all your questions answered. And this webcast is, of course, being recorded. You can find it after the broadcast right here on Facebook and the MedStar Health YouTube channel. Thank you, very smart people. Thank you, and continue putting survivors out in our streets. Thank you very much. Thank you for watching, and have a good night.